Good morning, everybody. My name is Stuart Schlossman, and we're here this morning with Patricia Pagnotta. All right, Tricia, now that we spoke about MS relapse, how about we ask you some questions about the infusion therapies that are out there, such as Lemtrada and Tysabri. You okay with that?
Sure.
Okay, great. So firstly, can you tell us about these two therapies?
Well, they're both IV medications that have been FDA approved for the relapsing forms of multiple sclerosis. They have two different mechanisms of action. So Tysabri's mechanism of action is to bind to a receptor that keeps white blood cells from getting into the brain so that you have less circulating white blood cells in the brain, and therefore you don't have the myelin being damaged by the immune system. So that's how Tysabri works. Again, it keeps the white blood cells out of the brain. Lemtrada is another IV infusion that is given, and it's a humanized monoclonal antibody that is directed at the CD52 antigen on cells. And it recognizes these special cells in our immune system that we believe are involved in the breakdown of myelin. And so it recognizes these cells, it goes in and depletes these cells. Literally, for lack of technical way, kills cells. So it goes in and kills these very specific cells that are attacking the central nervous system. And then once those cells have been removed, they start repopulating. So it allows for a resetting of the immune system. When I compare current disease-modifying therapies, including Tysabri, to a drug like Lemtrada, I like to use analogies. So I say to persons, well, all of the disease-modifying therapies, with the exception of Lemtrada, are like changing the volume on your radio. So you're turning it down a little bit more. That's what those drugs do. Lemtrada does a whole nother thing. I perceive that as like changing the channel. So you're more or less resetting the immune system with Lemtrada because it depletes those cells. When those cells regrow, they have lost their memory. The B cells have been killed, and the new ones come back are naive. They don't know to go attack the central nervous system. So it's really changing the channel versus turning the volume down.
So it's like when a computer starts getting slow in how it's responding to what you're trying to do, and you have to reboot the computer, you're rebooting the immune system.
Yeah, similar to that.
Similar to that. Okay, great. Thank you for that answer. So if a patient, though, has like bad veins, how do they find the right vein to use for these kinds of infusion therapies?
That's another really good question and a concern that lots of patients have. So Tysabri is infused once every 28 days. So every 28 days someone has to come in and we have to find a vein to use. Now we can use anywhere in the arms. Most individuals, I would say more than 95% of individuals, we can find a vein on. We're not drawing blood or we're not preparing person for surgery, so it doesn't have to be a large vein, it just has to be going into a person's vein. So every 28 days, typically we have no difficulty in most individuals finding a vein somewhere in their arm. Now those, I estimate, my numbers could be off, 5% of individuals who really don't have veins. I have had some persons who have ports put in, which is a device that's put in the chest so that it accesses a vein beneath the skin, and then persons can just access into that. So I have persons that have done that. It's a rare, but people have done that. Lemtrada is a whole nother different type of infusion. It's given 5 days the first year, you're off, and then you come back the next year and you get 3 days worth of infusions. So the amount of times that a person needs to have an IV access in that situation is so much different. We find that most persons can have one IV placed each course and use that same IV the whole time. We access, secure it, persons go home, they come back, and we still use that same IV. Some persons will get a second IV during the course of 5 days, But again, these therapies, most persons, there's no difficulty getting a small vein in either one of the arms.
Very good. What are typical infusion reactions and how are they managed?
So infusion reactions differ tremendously with these two therapies. So with Tysabri, some persons can have an anaphylactic reaction. So that means allergy. You know, persons can be allergic to anything. So when a person has an allergic reaction to an IV medication, that's pretty dramatic. Persons have a rash that progresses and becomes very severe, not just a little redness, but it becomes very noticeable redness, and they might even have swelling of their skin, difficulty breathing, wheezing. They may have chest tightness, they may have chest pain, they will have a change in their vital signs, and so they very quickly look very bad. Even a person sitting in the chair next to them would recognize this person is not looking well. So that's an allergic reaction. Tysabri is administered in a site where persons have been trained. They know all about Tysabri and they know how to deal with allergic reactions. So although it's very severe and could be life-threatening, the persons that are infusing that medication have been taught how to deal with that and successfully manage that. I haven't heard of a single soul dying from an infusion reaction with Tysabri. Other reactions that can occur with Tysabri, persons can get headaches during Tysabri. Some persons can feel a little antsy with Tysabri, but really headache is the most common infusion reaction during Tysabri. Most persons don't have a lot of difficulty during the infusion, and it's an hour-long infusion, and then persons wait for another hour after to be clear that they're not having an allergic reaction or any other reaction to Tysabri. Then they're free to go home and they come back the next 28 days. Lemtrada is much different. So Lemtrada is an IV infusion that is given over 4 hours. So the drug itself is administered over 4 hours. The waiting time after the drug is 2 hours. So minimally a person is in the infusion chair 6 hours. The first 3 days or more, depending upon the prescriber's protocol, a person is given a steroid prior to Lemtrada. So that may increase the infusion time anywhere from an hour or more on 3 to up to 5 days. Some people will give steroids up to 5 days. Some people just give steroids the 3 days. Now with Lemtrada, we know that persons are going to have infusion reactions. So there is a potential with Lemtrada that persons could have allergic reactions that would look the same as the allergic reaction that I just spoke of Tysabri. Happens very infrequently. Less than 1% of persons have an allergic reaction to Lemtrada. But it could happen. Now infusion reactions that are very common. In the clinical studies, 92% of persons had infusion reactions. And that's because this drug acts totally different. Like I said before, it is killing cells. When those cells die, they release chemicals that cause the body to feel something. And so most persons will have an achy sensation. They may have a mild rash. They may describe feeling, body aches. They may have fevers. And so the other thing I challenge MS patients to think about is, okay, I'm going to give you a drug that may cause you to have a fever, may cause you to have some body aches. You could get a headache. You could get, a rash. What's that going to do? Well, think about that. If you weren't getting an infusion, what would that do to your MS symptoms? Potentially your MS symptoms may be a little more prevalent. So persons who have MS, if they get a fever, all of their MS symptoms come back. Well, the good thing about Lemtrada, it's been very well studied, and we know that these infusion reactions happen, so we anticipate them. Again, persons who infuse Lemtrada have to be educated, have to be certified that they know how to take care of a person who's receiving this medication, that they know that these infusion reactions happen, and they're prepared to anticipate them. prescribers know it's going to happen too. So we all have protocols that we've designed for persons, and we anticipate these things. We give medications, steroids, we give medications, antihistamines, we give fever medications like Tylenol, Motrin, or Aleve. So we're medicating persons through the infusions. If they get nauseous, we give antiemetic medications. And so very few persons have not been able to tolerate a Lemtrada infusion. But it's a little different, and you need to know that you will have a reaction, and that's how we know the drug is doing its job.
So thank you for that answer. So if there was a bad reaction from, let's first go with Tysabri. If there's a bad reaction, the allergic reaction, is that something that's noticeable the first infusion, or is it where the histamines have to recognize what's going on or not going on? Does it happen after the second or the third infusion? When does that usually happen?
Allergic reactions don't occur with the first infusion because your body has to see something and say, oh, I don't like it. And so allergic reactions typically occur on the second, third, or more infusions. So with Tysabri, the allergic reactions are most common, dose 3 through 4, can occur out as much as 6 months. And if a person has a severe reaction to Tysabri, we can do a Tysabri antibody to see if a person has developed this antibody that says, oh, definitely they're allergic to Tysabri. And once you have an allergy to a medication, as much as one might want that medication, that's it. You cannot get a drug that you're allergic to because repeated exposures to a medication that you're allergic to can pose a higher and higher risk. And persons can die if we continue to give medications that persons are allergic to. So we can't manage continued allergic reactions, despite the fact that I just said that we can manage an allergic reaction. Yes, but we don't then go back and challenge and try that because we would be less successful every time because the allergic reaction would become more severe and more severe. And so if a person becomes allergic to a drug, that's it.
Okay. Now let's talk about the benefit, though, of Tysabri. How are people, that are using Tysabri, what made them first, what made the clinician use or choose Tysabri over another medication, and how is this going to benefit the patient?
So Tysabri is a very good, very strong medication. It was studied against placebo and had excellent reduction in relapses, disability, and MRI activity. So 67% of persons compared to placebo had a reduction in relapses. So that meant, 7 out of 10 persons had no relapses in the clinical study. Its MRI data is phenomenal. 97% of persons had no new or changing MRI lesions on their in that 2-year study. As far as disability, there was a 42% reduction in disability in individuals. So that was in their clinical study, their 2-year clinical study that brought that drug to market. That far exceeds some of the numbers that we've seen in other medications. Although there's not been a head-to-head trial that's been published to date with Tysabri, so again, it's a little hard to compare across trials. We're not supposed to do that, but all of us kind of do that. But there's not been a head-to-head trial with Tysabri, so we just have to look at it individually and see how powerful this medication is. Now, there's been a TOUCH program with Tysabri, which is their risk modification program. And that TOUCH program does a lot more than just look at the risk. It also assesses benefit. And through Biogen's continued work, we know that persons that have been on Tysabri, there have been persons who have reported improvement in their symptoms. So typically that happens 6 months and beyond, that persons will start reporting improvement in their symptoms. With a disease-modifying medication, our goal is to stop progression of disease. Our goal is really not to help persons improve, although we all want that. We want that for patients dramatically. But that's not what we want or we expect of a disease-modifying medication. So persons that have gone on Tysabri because either they have such severe disease that their risk of progression in disability is so significant that they, if they try a drug that's less effective, that we believe is less effective, the next time they have a relapse, they may really be very, very disabled, and their quality of life would be so significantly impaired. So that's why we would use Tysabri earlier when they haven't failed maybe several other drugs. But then there are the persons who have failed several other drugs, that they've not been strong enough for them. They've not held their disease. So they take this medication that has been proven to be very efficacious in an effort to try to halt their disease. Along the way, if they get better, that's a bonus. And we've seen that in some individuals. So some people get the minimum, controlling, stopping their disease, and then some people get that bonus of actually starting to improve.
Great. Thank you for that response. Now we're going to go back to Lemtrada. So what is the efficacy data of Lemtrada?
So Lemtrada was studied much differently than any other disease-modifying medication that we have now. Every other disease-modifying medication has been compared to placebo, which is an inert medication that does nothing, has been tested to do nothing. So Lemtrada was studied against an active comparator, Rebif, which is a medication, an interferon that we all know is given 3 times a week, is very efficacious and has done well for patients. So Lemtrada was studied against that. So when you hear of the efficacy data, it's all compared to Rebif, not compared to a placebo, so compared to a very good drug. There were 2 clinical trials that brought Lemtrada to market. One was a trial in persons who had had a relapse and had been on a disease-modifying therapy, so an active MS patient who had previously been on a disease-modifying therapy, and those persons could have an EDSS up to 5, which is pretty significantly impaired. Those persons had a better than almost 50% reduction in relapse rate. Their disability was improved by 42%, and their MRI data was improved but not clinically significant. In the persons who had, the other study, persons who had not been on a disease-modifying therapy medication prior, were active MS patients but had not been on a disease-modifying medication. Their EDSS only went to 3. Their relapse rate reduction was 55%, again compared to Rebif. There was not significant disability progression, and there was not significant MRI disease reduction in T2 lesion load. So the data, again, I would ask persons to consider that it's not against placebo, it's against an active comparator,
Okay.
but good data.
You say EDSS. A lot of people do not understand what EDSS is. So before we get back into all these other things about the actual infusion, the actual medication, could you please explain EDSS?
So EDSS is Expanded Disability Score, and so that is a common measure that is used in all clinical trials measuring persons' disability. It's heavily laden on walking skills, but it measures every part of the central nervous system, your strength, your sensory symptoms, your perception symptoms, your visual symptoms, your bowel, your bladder, every different part of how your central nervous system affects your body. But again, heavily laden on walking. Persons have critiques about the EDSS that they think it's not the best disability scale, but it's been used in all the clinical trials. So it is what it is, and it's what we have, and so we can use that and compare it versus if we started using a different disability scale at this point, persons would say, well, you introduce a different variable. It's just a measure of disability commonly used in clinical trials.
Great, thank you. So if there's a bad reaction to the patient while they're being infused with Lemtrada on any one of the 4 days that you, or 5 days, 4 or 5 days during the 4-hour process, what happens? What is done to the patient to help them combat the bad reaction, and what kind of bad reaction might they have?
Okay, so if you're talking about a bad reaction, I would say that's an allergic reaction. The only bad reaction that happens to a patient is an allergic reaction. So if a patient has an allergic reaction, we would do the same. We give medications to help open up the airway. We give antihistamines, and we may give a medication to help support the heart. Medications that would support the systems that are failing, and an antihistamine to help bring down that allergic reaction. And then depending a person, how severe, may need actually to go on to the hospital to be stabilized further. And that happens again, either Tysabri or Lemtrada with an allergic reaction. But when you talk about infusion reactions, again, bad reactions are allergies. Infusion reactions with Lemtrada are common. So infusion reactions with Lemtrada are things like a rash, things like a fever, things like body aching. Some people will complain of a little nausea. Some people may actually feel that nausea may be something that may go on to have vomiting. So we have medications that we give for that. Benadryl. I pre-medicate persons with Claritin and Zantac starting the day before, and I give them that through day 8. They're only getting 5 infusions, but I pre-medicate them, keep them comfortable. Before I start their infusions, even on the days that maybe they're not getting steroid, because remember I said they would get a steroid to help dampen those infusion reactions, I give them Tylenol, Motrin, or Aleve, and I give them a little bit of Benadryl. So I anticipate these things are going to happen, and I'm going to give medications to make them less severe. And I have had persons who have sat in my chairs and tell me that they don't have any infusion reactions. But that is not the norm. 92% of people are going to have an infusion reaction. Only less than 1% have been a reaction that has not been able to be tolerated. So again, everybody except that less than 1% is able to get through these infusions, and the healthcare providers that are administering the medication are well informed as to what they can do to help persons along. And so it is, in my mind, a very well tolerated drug with a good protocol. But what patients can do to help make that better, I tell persons, don't come to your infusion underhydrated. So stay very well hydrated, drink plenty of fluid, make sure that you are not dehydrated. And that's difficult for some MS patients. They don't like to drink a lot of fluid. So if that's you, please make sure that you're telling your healthcare provider that, and they can give you extra IV fluids. But staying hydrated is extremely important. Our bodies are mostly water. And so we need that water. That really helps. So staying hydrated. Thinking about eating well. Thinking about make sure that you've slept the best you can the night before. You don't want to come into any new medication not doing your best. Person should think about whether or not they have an infection. If you've got an infection, you don't want to take a medication that might then potentially lower your immune system, even if it's only periodic, for a short period of time if you've already got an infection. So eating right, sleeping well, hydrating are the things that you can do. And if you're sick, I know that persons may have waited for this drug for a long time, but if you're sick, we need to postpone that infusion until you're feeling better again.
So the good news, though, about Lemtrada then is that allergic reactions are extremely rare. And the good news about the infusion reaction is that it seems to be all combative. There's an answer for it all, for as far as how to treat the infusion reaction without it becoming severe.
Yes, I mean, we know these things happen. We very reliably have seen them occur again and again in persons. We've developed protocols to help people through it, so it's not a surprise. It may be, persons may think, oh my gosh, but we know this. So we're well equipped to take care of persons and to make persons comfortable. And again, most patients, if they're educated and they do what we ask them to do, hydrated, eat, sleep, and then allow us to give medications, then they do very well too.
And when you speak about this, it's not just saying about your center, saying how well you're prepared to take care of the patients, but that every infusion center that is going through this process for the Lemtrada patients are all basically educated the same way as to the process and the protocols that need to be held for the benefit of the patient.
Yes, again, this drug has a REMS program, just like with Tysabri has a REMS program. So prescribers, persons who infuse, and patients are all enrolled in this program. And so that means that persons are all educated. You can't get Lemtrada or Tysabri in your home. It has to be given in infusion centers where persons have been educated, they know what to expect. And so because in the clinical trials we knew what was to expect with these drugs, persons are educated. Their center has to be able to handle these things. So it's not my center, it's every center across the 41 countries that Lemtrada has been used in.
Wow. Well, thank you. Thank you for all your answers today. They were all excellent, and I am sure that there are going to be many people out there that are going to learn greatly from this interview. Thank you very much.
Great, thank you.